Dear colleagues, congresses, especially for the last 5, 6 to 10 years, this also was the case in the past, but after having easy access to knowledge for all of us, as you all know, quite rapidly, if you're a member to PubMed or to different journals, and as you all know, at universities, you can have access to so many journals. Same for children and adolescents and adult psychiatry, it's the same thing. You actually should have a certain level of knowledge, but in practice in particular, it's also very valuable that you work with as mentor, just like the surgery. The surgeons at the same time need a mentor. But unfortunately, if it is something that we're doing in our routine, unfortunately not. Why? I think it is something to the flexibility of our field, because we all have our own style of doing treatment, and people all have their own systems, and they somehow continue as a settled, established practice. Whether this should be the case, yes, why not? Because we're actually practicing art as a medical doctor, and as a psychiatrist, I would say it's an extra art performance to us. We're using our skill of relationship and communication. It's possible, for example, that you can check from the internet while interviewing with the patient to understand whether there's a cardiotoxic effect of a drug or drug-to-drug interaction. Even before prescribing it in front of the patient, you can actually check it on the internet. So it's all about how we manage the skills, communication, and it's pretty obvious that there are some issues. And that's the reason why I would like to make this talk. I mean, there are, of course, certain experiences that you make throughout your life in your career, and they're very valuable. And that's the reason why I actually, when my colleagues asked me what actually would you like to present, I said not delivering a presentation, but some challenges and solutions in the clinical interviews. If you have a child, an adolescent, or a parent, we all are together during clinical interviews, and I think it is important to underline a few points, and I will actually go through them with you without boring you, because I know you're all tired, but just a couple of main topics that I would like to go through. Let's assume a child or an adolescent wrote to us with a specific problem. Of course, I will speak about the ideal conditions, but at the same time, forced also conditions and the more tight processes that we go through. Of course, first you have to know the ideal, but before the ideal, there are also some forced conditions, and we have to manage the interviews under forced conditions. We do not have the luxury to say we're not working in the ideal conditions, so let's skip those. You cannot say that. Why? Because eventually, as a healthcare provider, if someone asks for our help, we actually have to help them as long as they ask for it. We're not actually taking people and from the streets and trying to treat them. They are knocking on our doors. Maybe the conditions are not ideal, maybe problematic and challenging. It is not like we have so much patient load, we have limited time and so on. You know, it was in 1998 that I became a specialist at Vakif Guraba Hospital, and I was actually taking care of 65 patients on a daily basis at the clinic. As you would assume, not an easy task. But still, while examining 65 patients, you still can build upon the patient and put a diagnosis and make the treatment. Even under challenging conditions, we should not forget who we are. Let's assume a child. As I'm telling you, no one will bring your child to you just for nothing. For a psychiatrist in particular, there must be a problem. And of course, in taking the child to the psychiatrist, even with the first step on the door, you start the treatment and clinical examination. And it continues until they leave the room. So how do you manage it? How do you approach your patient during this period of time? Managing it from the perspective of the child, the parent would make you successful. It is not actually the medical therapy that you prescribe, the milligram, the combination of drugs, and so on. They would not change a lot. I can speak it so clearly. Because eventually, if it doesn't work, of course, you shift to another drug. There are alternatives, guidelines. You can always actually find an alternative to the drugs that you prescribe. But what is important is you have to ensure for compliance to treatment, including the family, the parents. It's something ethical, of course, because what we actually mean by compliance for the treatment always starts with the relations you build with the family, with the parents. A parent may leave the room crying, or a parent might leave your room laughing. If they are leaving your room crying, it doesn't matter which diagnosis you put, there is actually a style also in declaring the diagnosis that you put. Of course, you're not giving false hopes. I remember a deceased professor, and because of his own anxiety and a neuropsychiatrist and good knowledge about his profession, but because of his own anxiety, for example, for a 16-year-old adolescent to mild to severe mental retardation, don't worry, he'll be okay. He even will become an army member in the future. It is not like giving false hopes. Of course, he wasn't doing it with bad intentions. Probably that was actually a way of coping with the patient and handling his own anxiety. That's not what I'm saying. Whatever it is, but your style of expression is important. And the second of all, you know, we're dealing with children, and it's an ongoing process. Clinically, you can have huge experience. You can have good clinical experience and understand everything immediately. For example, like the other physicians. For example, we do not have, for example, blood tests and so on. It's maybe a pro and con on both sides. But from the other perspective, what I can tell you is that we're just dealing with an uncertainty. If a parent is asking you a question about a clinical diagnosis or about the prognosis of the disease, you cannot be crystal clear. As this is the case, how would you well explain so many things to the parents and the child? It's all about the communicative skills of the psychiatrist. Of course, for being a good psychiatrist, you should have great communication skills, but for a child and adolescent psychiatrist, it must be more. Because it is not only the child, but also with the parents and the circle of the parents, the school. You actually should develop very good communication skills. Therefore, we assume a huge responsibility here, and we should not make any mistake. So, what you see when they are leaving the room, even if you actually have a diagnosis to make, and even if it is going to be a severe one, to the family or the parents of the child, you have to build empathy. During my residency, I heard this guy, for example, this child is a failure. and do not handle him. You cannot handle him. There is nothing you can do about him, her. Even there are clinicians still having the same attitude. We, as a medical doctors, once you are a parent, and if you are a child psychiatrist, you should always keep in mind that you're a parent. Think about a child with autism. I mean, if you sent that child saying there's nothing we can do about him, her, then it would be applicable for the parents as well. But you can say, for example, it is a huge task if can possibly urinate on his her own, if can speak 10 words. Even showing the origin of the pain is something an advantage. I mean, you should not actually say there is nothing we can do about the patient. Then you will no more build empathy. You probably would be very upset and angry if someone said this for your own child, and you probably never comply with treatment. So this is one mistake, not only for autism, of course, for mental retardation, for personality, behavioral disorders, and all. Therefore, especially, we have to be very sensitive about the way that we use language. It must not be an offending one. Of course, we should be speaking the truth, but we have to use a good language in saying that. And on the other hand, we somehow should give some hope. I mean, of course, there are hopeless cases. Of course, there's no doubt about it, but there is actually a relativity. For example, a child with severe mental retardation, even if you provide toilet training, or if, for example, make sure that they can make actually self-care, it's something good. By 50, 60% of the workload of the parents will be lifted if you handle the self-care. Therefore, in your diagnostic approach, in particular relationship to the parents, please be kind. Second of all, we live and we work under challenging conditions. Majority of our patients are not aware of the reason why, for example, they're brought to us. Even, for example, they are taking them to the child psychiatrist, saying that, for example, we will have a physical exam. Or, for example, taking the child to the hospital saying that this is my friend. Especially for the adolescents, they actually immediately will understand it. So they start the interview in a negative manner because they've been cheated in bringing them to the hospital. And therefore, you do not have a patient that can communicate well. Therefore, the second thing about child psychiatry is you have to develop a technique for starting the communication interview with the child. About the ideal conditions, I would like to say, and apply it also in non-ideal conditions, to the extent possible for children over the age 5, 6 years. Please start to interview with them, not the parents. It is just 5 minutes that you should see the child alone, without the company of the parents. Trust me, even for 5 minutes, you can actually collect so much clinical data when compared to the company of the parents. And majority of the children over the age 5 and over, they are okay with getting into the room alone, maybe yourself, maybe the secretary or the staff. Of course, some of them maybe will not enter in the room, but majority of them would accept it. The way that you say hi, asking the name, introducing yourself, and just spend some time at the playground. Even these things, maybe a very short period of time, but still so valuable observation. And maybe just one or two words out of the mind of out of the patient would be very helpful in diagnosis, or even the posture, the way of speaking, the way that they build relation, whether they ask you to talk or not, the way they answer the questions, reasonable or not. And for example, a child at the age of 10 we're talking. And in my lectures, I always say in communication, for example, with the children, you cannot jump into the topic immediately. You should never ask for any complaint. Even if you have time, never ask that question. Once you are with a child, just try to get to know each other. Ask some questions. It could be, for example, the football team that they are fan of, school-related, friends-related, and so on. Quite interestingly, a child at the age of 10, for example, we were talking, how old are you, which school you attend, do you have a sibling, and so on. How old is he, she? And always saying, I don't know. For example, date of birth. For example, not knowing the date of birth, write it down. But there was actually no concept of birthday in the past. But now, as you all know, there is the concept. It is April 12th or March something. I'm speaking about the child at the age of 10. About the profession of the father saying, I don't know. I mean, if a child at the age of 10 doesn't know what the father is doing, it's something valuable. You don't need any blood test. You still can have the blood test run, but there's something else going on there. I mean, it does not know something that they should know, or some irrelevant answers that they give. You ask a question, for example, quite an irrelevant answer, and you are just surprised. And sometimes the rules are changing, and they start asking you questions. Do you have children? How old they are? And it's just the beginning of the interview. The very first minute, they start questioning us. Trust me, all of these things have clinical relevance. That's the examination that we are making. That's what we will take out. Or maybe never speaking at all. You ask questions, no reply. It is actually just like selective mutism. No, not, but still, probably forced at the age of 14, forced to come to the doctor and just making fun of you. All these things, again, bring us some data. I mean, we have a lot of data that we can take out. I mean, it's not only giving a scale to write down, or much more valuable than asking them to fill in a questionnaire. Or, for example, wearing a hat and even no eye contact at all with the child. They totally cover their face, never look you in the eye, and just answering with one word only. Asking a question about the school in such questions, some absurd answers. How is the school? Good. Which classes are okay? All of them. And then the mother is saying a total failure at school. So it's important to collect data directly from the patient. So clinical interview is the most valuable diagnostic tool that we have in hand. And history taking. And in years is also as useful as the clinical interview. And if you're asking me, it's even more valuable. And it is 2023, the modern child psychiatry, what would say, what's the diagnostic tool that we will have by taking history and the clinical interview, nothing else that you have. All the scales, all the scores, all the questionnaires, all are supportive tools, and they are not diagnostic. HIST4 and this test and then NOXA, and even if you ask them to perform all, I know it from the families always coming with the tests in hand and crying. There is mental retardation of the child. You know, we're taking history and all. At the grade 1, for example, primary school, when started to read, one of the first. Think about it, grade 1, primary school, if start to learn to read and write, not possible to have any mental retardation, not possible. even 60 at the IQ test with a score 60. So it's still so clinically relevant and a different perspective, those performing the test and not having any psychopathology and not having any knowledge about test information. And there is some subscores, there is mental retardation. Even writing down the average score, say normal, so it will be a comfort for the parents. Even if the average score is not okay, the test alone would never provide us full information about the mental capacity of a child, although this is one of the most objective things. As you all know, Turkey, it has 4 tests that we're using. There are some attention tests that we use. Trust me, they are more objective. I mean, they make a measurement. But this measurement, I would say, is not like measuring with a ruler. For example, the height, 170, maybe 171 for me. No, that's the case. And during the test, for example, they're bored, they're intentional, not giving normal test answers. And if it's actually not a very experienced person performing the test, saying, for example, lacking attention, not willing to complete the test, and maybe you can say a mild mental retardation. If you write it down and you also have a report, then that's the end of the future life of the child. A clinician, a good clinician, will understand the mental retardation of a child in 3 minutes. If somehow you know about the education background, and also in particular the Turkish education, you will ask them to read, to write, ask questions with maths. For example, what is your favorite, for example, sports, football, and saying which is the sports club that you are a fan of, would say Galatasaray. And if saying Icardi actually had that much score, it doesn't matter. Maybe in mathematics they're not okay in addition problems, questions, but still not speaking about the mental retardation. We need a holistic approach. And in this holistic approach, there is one thing we should always keep in mind. The patient in front of you, it could be your own child. They probably never ask you, but they're always asking. For example, while prescribing a drug, if you have a child, would you prescribe it for your own son, daughter? Yes, of course, I will. Otherwise, why would I prescribe it? And by the way, I used the drugs on my children. So it is such abstract way of thinking that people, the patients, the parents believe that you just prescribe any drug. Of course, you can ask this question to a professor of your age, but this shows the distrust of the people. I mean, in all the processes, in particular diagnostic processes, the clinical interview is so important. In anamnesis, again, it's you actually taking the history. So there are some parents that they will speak for 5 hours, but they will speak in vain. So they actually tell you a story of their own, but that's not the case. You should be directing the parents. You should be managing the parents in taking the history of the patient. I mean, you have to narrow it down. For example, if they are not speaking reasonably, then you have to stop them and ask specific questions. And you have to direct the parents by asking questions. And in anamnesis, the child should never be in the room. And there's no excuse for this. They take everyone in the room and saying, you can start talking. That's not the case. I mean, this is something totally against the core, the spirit of the psychiatry. I mean, not possible for everyone to speak in the way that they want. And half of the things that parents would tell you not possible in the company of a child. You can ask some of the questions about the child when the child is in the room, because they will not answer. The parents will not answer the question. Or the parents, for example, talking with the parents about the child is so sensitive. Yes, possible. You can have interview altogether, but not the very first ones. It is something that you can do later if you're going to convey a common message, a collective message. This is the case also for the state hospitals. You can spend 5 minutes, 10 minutes with the parents, but use the proper interview technique. We actually had a friend, then 7 patients, one to each other, and if any raises this one, or attention deficit, prescribe this thing. It's just like pointing your finger to the child and prescribing a drug just with one sentences. So you need separate interviews with the parents and the child, because the children will not speak freely. Same for the parents when they have the company of each other. And at the same time, any rhetorics that you make will be used against you, and the parents will never come and visit you again, and neither you nor any other child psychiatrist. You don't have the right to do so, because it is a must for us to ensure compliance of the child to the treatment in special conditions. For example, if there's something wrong with regards to the internet use at home, if you're going to fix it all together, yes, the parent and the children all together possible. For example, how many hours to spend for playing games on the internet and so on. Yes, you can do it for spot things, but other than this, you need to interview separately. Same for adolescents. We have a therapeutic relations with the adolescent, so the adolescent will never actually tell about their stories if you speak separately with the parents. 90%, if they tell you something so special, so private, and always asking you, will you tell it to my parents? Of course, there are things that you have to also tell to the parents, but if it is not something so important, then I would say, no, I won't. We're just speaking alone. You're telling me, and I will never tell your parents. If there are things that you want me to convey, yes, for example, I don't want my father to beat me, but don't tell my father that he's beating me. Of course, I have to ask the father not to beat you. It's something that I'm doing to protect you, but my father will be mad at me. No, don't worry, I will handle it. So it is either the family, the parents, they at the same time have their own privacy, and therefore they all have something in their mind, and they know that you are under oath, so you will not say it. And it's actually not a major issue, but sometimes we experience such things that we do not have the luxury not to tell it. If the child is saying, I'm going to commit suicide, you cannot actually hide it from the parents. Or if using drugs, illicit drugs or alcohol, again, of course, by speaking to the adolescent, it's okay. That's the reason why you're coming here. I have to share it with your parents. And of course, with regards to the reaction of the parents to the issue, as you all know, our main role in here is to make sure that your parents behave you properly. In children and adolescents, as they bring the child to the clinic like a criminal, the child feels, I am the problematic guy of the home. So they bring me somewhere, a man or a woman is questioning me, and then they will be imposing me a penalty. It could be prescribing a drug or deprive of the internet, for example, if using the internet for 10 hours, reducing down to 2 hours, or some bans, and that's already the perception. But you have to make sure that that's not the case. It's actually a communication problem, and the problem is not unilateral. We're always telling to the child, as you can see, I speak more with your parents than you. I'm also talking to them. I'm also telling them how to manage the conflict between you and your parents. And that's the reason why they are actually coming to the interview. This is not a court, and it's not a mechanism to punish people. It's just a platform that we try to find a solution to a common problem. And I'm also telling your parents what they should do, and they're all okay with this. They're so positive about this. So, two groups of children that we have. One is have an insight about the psychopathology that they have, and they would like to get some help. It's quite easy for this, because at the first minute when you're saying, how are you doing, and so on, you don't need to ask me anything. I'm a very naughty boy, for example. Why you are naughty? Because I'm hitting my friends and so on. And you know what? I'm actually expelled from school, and I never asked anything. It is, I don't know, it could be the manipulation of the parents, but there's an insight of the patient. Or from time to time, I ask, for example, to the child if it's ADHD from the behaviors and the attitudes. How is the school? Who are your best friends? And so on. What you are doing during the recesses? Are there naughty children in your school? And so on, especially for the primary school ones. Yes, who is it? Me, they're saying. The naughty, but because they're saying that my teacher doesn't want me at school. That's the reason why I'm not going to school. There's just one group of children and adolescents. Same for adolescents, for example. Eventually, I'm in conflict with my parents. And that's how they are acting, or that's the way they're treating. Speaking about anxieties, if low academic performance and so on, or exam anxiety, they're speaking of this. But the actual problem is not in the children, but mainly the adolescents with no insight at all. They have no idea why they are there. Why am I in front of the sky? Why they bring me to a hospital? Why I'm visiting a psychiatrist? Trust me, it's not an easy task to communicate with such clients and patients. For example, you cannot ask a child, what's your complaint? Once you said complaint, they must have an insight. And in a small children, you should never accept it. You should never expect it. So it is after the warm-up. The schools, teachers, friends, siblings, and parents, and what you're doing during your leisure time with your parents, which sports you like, and so on. This is the warm-up, and after the warm-up, you have to do something. I don't know. You should make a touch. I mean, if you have time, of course, you can see the child for successive 3 sessions. But if there's no time for this, maybe you can make such an introduction to the children, even to the adolescents. You have already introduced yourself. I am a psychiatrist and a psychologist and so on. I don't know whether it would make any sense for the child, but especially until the recent, again, for example, the movies and the on the TV, people understand it much better, but they always have in mind that you'll be prescribing a drug. What we are saying to the children is they mostly have fears, anxieties, sometimes low, poor academic performance, or getting bored at the classroom environment, or having some issues with the parents. They are coming to us. Is this the case for you as well? You just ask the client, and then after this, the child starts telling you, just will tell you one of the symptoms that you listed down, saying, I'm okay. So it means that that's the type of the child or the adolescent that does not have any insight. And they will start talking after a couple of sessions, but they're saying, yes, I have fears. Example, I have the fear to take a lift, or lightning, rainfall, I cannot go out, I miss my mom at home, or a behavioral problem. Yes, I have difficult times with my friends, I have no friends at all, no one loves me, and so on. And they start speaking as symptom-based, and that's where you would pick something and question. The same thing is applicable for the adolescents as well. But at the adolescents in particular, you can clearly ask, what is the reason you are coming? I mean, is it your parents that take you here, or yourself?
Now, within the period, This is really a relationship model. And the point is to bring the child back again the next time. Mostly, those resistant children to talk to you, if you would manage that process effectively, even may walk out the room quite satisfied. Even in the most traumatic cases, it happens quite rarely that the child walks out the room with a big irritability, and I advise the parents not to hold the interview. It doesn't make any sense, and you go back home and get calmer, and we'll talk to the parents, and then you'll bring the child back. But it's quite rare. If a child is irritable, and let's assume the child walks in not alone, I would accept the child alone to the interview room. This is based on my clinical experience. Number one is I would be quite neutral without the parents. And with that neutrality, I think what I see would make more sense. You may accept them together, but so as not to speak about the problems. And if there is resistance, then I would accept together. And I'm not speaking about small age children under the age of 5. It's rarely that they would come alone. Of course, you would accept them together with the parents. You can speak about the symptoms together. And sometimes the parents would complain. Well, if it's a child at the age of 3, he would understand everything. I mean, even if he or she would understand everything, what is the problem? I mean, at the end of the day, there is nothing to be too sensitive about. But if it's an older child, as the child gets to understand what's going on, what is really important is to make the child or the adolescent feel that he or she can speak about things that he would withdraw himself with the parent in. Maybe after a while you would accept with the parent and talking, just doing some small talk with the parent, even if it's a public hospital. I mean, it's just a few toys that you would need to find there. I mean, it's a puzzle, it's a toy, then the child would be attracted. As he or she plays with the toys, you make an introduction. And then you tell the child, is it okay if we play together for like 5 minutes and your mother would wait outside? 99% would say, okay, if there is no separation anxiety. I mean, you wouldn't be able to send the mother if there is separation anxiety. With the link on, you would take the mother out of the room. So what happens then? The child would be more relaxed. With that relaxation, you would have a better and more comfortable examination of the child. And if you have time, it's even more okay. Let's come to the diagnosis. For pediatric psychiatry, diagnosis on one hand is the easiest thing on earth. Or let me put it this way, if you are an experienced doctor, once the kid walks in, as of the 3rd minute, a diagnosis would pop up in your mind. Whether or not they would be accurate, they would pop up, but we don't know at that point whether these would be accurate or not. And popping up of the diagnosis would mean that you know the job well. I mean, the better doctor you are, the quicker you operate a patient. The quickest you would diagnose in psychiatry, the worst of the doctor you are, because you're expected to speak for hours. I wouldn't say you need to make the diagnosis, but you need to shape up things in your mind. Only then you would ask the true questions and get the correct anamnesis. Otherwise, you would be asking really blank questions, meaningless. Most of the scales are, meaningless to if you would ask me, because the symptoms are not present. So if something is popping up in your mind, and to make an analogy, in psychiatry, making a diagnosis is like making a jigsaw puzzle of 1,000 pieces. I would rather say in pediatric psychiatry. Why? Because with the development of the personality, the psychopathologies would keep on changing and fluctuating at the point of symptoms, and comorbidities start to come up. In other words, as you keep concentrating on one particular diagnosis, you would understand that there are side diagnoses at the same time. So you need time to be accurate, and at the same time, you keep suspecting in your mind about certain diagnoses, but you need to ask the proper questions. Take a 1,000 piece puzzle, and 200 pieces already made. And out of these 200 pieces, as you see the 200 pieces, you would have a clue whether it's the Pisa Tower or Galata Tower or the Eiffel, but you're not sure. It resembles a tower, but you would have, some idea. This is, what we do for a living. When you jump into conclusions, you would say Galata Tower, but if you end up with Eiffel Tower, you make an error. Of course, you always have the right to make an underdiagnosis or overdiagnosis or misdiagnosis because of these reasons, but I don't know if it's being used, but there is preliminary diagnosis all the time that will save you. Preliminary diagnosis, you can say. Of course, you cannot enter that way into the software or the system, but you would say, the parents, my preliminary diagnosis is there is impulsivity and ADHD in your child. Preliminary. But at the end of the day, you might end up with some neurodevelopmental pathologies. Therefore, I'm not quite sure of this because you're at the same time suspicious of Asperger's in the child. It's not one-to-one Asperger's. You cannot easily say it's Asperger's. You're confused. But in 3 sessions, you may end up with the Asperger's diagnosis. But the father may say, we came to you, and the first time you say it's ADHD, you can treat it with a medication, but you cannot, right? If it's Asperger's or obsessive compulsive disorder. If there is obsessive compulsive plus ADHD, methylphenidate wouldn't help you, and they would come back to you saying it's not corrected. So you should always share with the parents the possibilities. That wouldn't make you smaller in diagnosis, but would strengthen your hand. Just talk about the possibilities, the other possibilities. Probably the patients would always say that we went to a doctor, he said this may be possible, or the other way around. Probably he was talking about the possibilities. People want to get a quick answer, but it's not really very easy. And you cannot say it's after 250 pieces of the jigsaw puzzle, you cannot say that it's just one specific tower. This is how challenging pediatric psychology is. You start with ADHD, you go through Asperger's, and in 6 months you can end up with bipolar diagnosis. So it's really a very quick change in the moods and psychiatry of the patient that you cannot end up in quick conclusions. So enlightening the parents, particularly about diagnosis. Okay, we need quick and clear diagnosis, but always alert them about the possibilities. Don't scare me, the parents may say. No, I'm not scaring you. These are just possibilities. I'm just explaining by drawing. These are present, but this and this can be seen together. Therefore, this and that are the risk groups. Probably we are dealing a lot with a condition, the MDD cases. These are quite challenging cases, and at the end of the day, there is no proper response to therapy. They wouldn't comply with psychotherapy. Only with a good and proper management and collaboration of the family, you can just progress. And they're not responding to medication most of the time. So just imagine most of these cases are diagnosed with ADHD because there are many cases who have comorbidities. But methylphenidate makes these specific groups even worse. Or you combine it, even worse. So you need to question things there. There is, what we say as treatment resistance, and I will finish off in 2 minutes, is really very important that you need to understand why there is a certain group of people who would respond to treatment quite effectively and another wouldn't. So maybe you need to revisit the diagnosis, or maybe you need to revisit the comorbidities. I mean, I wish we could have seen pure cases all the time. This is ADHD as it's stated in the Adolescent scale. You can tick the tick boxes, and then you would give the medication. Everything would be a bed of roses. But it's really a very small group of people, patients. And the best possibility would be, is to come against you. I mean, according to my daily experience, ADHD wouldn't harm the dynamics of the patient. I mean, it's not about just jumping on the sofa. It's not that, if the lessons are going bad, there are problems at the family. Impatience would be really important symptoms of impulsivity, but that's not the problem. The problem is irritability. Everything. They are just objecting to everything, would object to go to the toilet. If there is a defecation problem, it's a symptom of a major psychopathology. People and all the students really are miserable because of the defecation of this particular student, but the student himself is not disturbed at all, which is a big problem. Doesn't matter which cause it would stem from. So we need to read psychopathology correctly. That's why we need to explain about the treatment processes to the parents together with the side effects of treatment as well. And then we need to be very, very, very clear, but sometimes you cannot be that clear at all. I need to finish off, but unfortunately, we are facing a group of doctors who, when treating a 5-year-old child, ADHD, autistic spectrum disorder, comes in, they talk, they're just taking a good history, diagnostically would say this resembles autistic spectrum disorder, may resemble, because we are not 100% sure in our diagnosis at once. It may be neurodevelopmental disorder. But don't rush. Diagnostically, if there is no classical autistic presentation, don't jump into this diagnosis of autism and to enter it into the system. Deleting the misdiagnosis would be a problem. There is no problem here diagnostically, and this is maybe a correct suspicion, but can we say, if you like, I can prescribe you medication? Come on, we're doctors. I mean, if the child comes with an abdominal pain, can you say, if you wish, we can operate? If it's okay for you, let's transplant liver. Is it okay? This statement is not right. This I hear a lot. Young colleagues, so as not to take any risk, they're making this statement. Don't prescribe medication, but don't make this statement because it wouldn't corroborate with practicing medicine. If you want me to. I mean, this is not the right statement. We are authorized to prescribe. You prescribe, and they would decline using it. I don't care. But if you like, shall I prescribe you medication is not the right statement because it would contradict with the spirit of pediatric psychiatry. And in the near future, people would tend to underestimate what we are doing. This is a reason why other specializations underestimate us. Clinical psychologists used to be the most problematic field. And please make sure your diagnosis, if treatment requires you medication, prescribe it, and you cannot force anyone to use it. I don't care. But if you like, I can prescribe you is not the right statement, and you cannot find this statement anywhere in the literature. I'm just finishing.